All right, it's 8:30. Let's start so we respect everybody's time. Welcome. My name's Michael Fine. For those of you who don't know me, I'm a writer, community organizer, family doctor, and a public health guy, and president and board chair of Primary Care for All Americans. You're joining people from 27 states and 211 zip codes who are here to build a movement and a healthcare system for the United States that is for people, not for profit, and that starts by providing primary care to everyone in every American neighborhood and community. Our first job has been to bring everybody together as a community in these Zooms so that everybody knows there are other people who believe that we can do this and do this together. And then once together, we want to work with all of you in your own neighborhoods and communities and turn everyone's attention to providing primary care to all. Neighborhoods and communities are the places where America happens, where the police stations and firehouses are, where our schools are, where we get our clean water, where our garbage pickup happens, where the Boy and Girl Scout troops are, where the little leagues and soccer leagues and boys and girls clubs and the Ys are, where people play pickleball and softball and pick up basketball in the evenings in the summer. Primary care is no different. Primary care is an essential service one communities can and should provide for themselves, and do it so that we all get great primary care right here in our own communities. Tonight, you're going to hear how primary care has the power to create order out of the healthcare chaos we all experience. How, as we work together to provide primary care to every single person in the United States, we will finally be building the healthcare system we all want and need. More than that, tonight we're going to start talking about how we're going to get this done. We're going to spend a little time on it during the course of the formal presentation, and then we've left extra time at the end for questions and discussions about our strategy and tactics, about how we're going to start working in 25 neighborhoods and communities all across the United States, about how we're going to start working with states so we start training the nurses, doctors, community health workers, social workers, pharmacists, physical therapists, and so many other health workers from our communities to be able to be in our communities, providing the care our communities desperately need. We're going to talk about how we're preparing to work at the federal level, making sure we spend healthcare dollars the right way for people in communities and not on the folks in pharma, hospital administration, and insurance companies who have way too much money already. So we need to get this done. So we all have someone who knows us, who is there for us, and who listens. It's now my great pleasure to introduce our moderator for the evening, Dr. Aliyah Safi, and to thank the Zoom Committee of Primary Care for All Americans, which organized this Zoom, Dr. Fernandopulle, and all the presenters, and John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. Take it away, Dr. Shafi.
Hi, good evening, everyone. Thank you all for being a part of PC4AA, Primary Care for All Americans. Where together, we're building a movement to provide healthcare for all people. Healthcare for people, not for profit, in every neighborhood and community. Tonight, we are here to both teach and learn from each other. We encourage you to ask questions, put them in the chat, and we'll answer them. We'll answer as many questions as possible after we hear from our keynote speaker, Dr. Rushika Fernandopulle. Also, there's a brand new feature we have. It's closed captioning in Spanish. If you can go below in your toolbar and hit the CC option, you'll be able to find it. Before that, we have asked 3 individuals to tell us a little about their experience in our current healthcare system. First up, we have Justin Davis. Hi, Justin. Can you please tell us where you're from and share your experience, please?
Absolutely. Hi, my name is Justin Davis. I'm from southeastern Wisconsin. I own a health tech company here. I had a pretty incredible run-in with the power of good primary care long before I even was smart enough to understand the value of it. So my primary care experience was something I stepped into when I married my wife. So I just happened to, at the time, need a new doctor. So I adopted hers. Obviously, at the time, I didn't know any better or how to find a doctor. So, that's what I did, is I just took on hers. He ended up taking care of both of us. I didn't think much of it at the time because I didn't have a lot of experience in it. But he essentially managed everything from my wife's OB needs to my osteoarthritis and everything in between. Thought it was pretty cool and different, but I really didn't understand the effects of it until a few years ago. Fast forward now some years, had some children. My daughter was going through some mental health issues at a time that put us, on a year-long wait to get to see a child psychiatrist. And this is right during COVID, really, really terrible time, right? We were struggling. We're super scared for what she was dealing with. And I vividly remember going into my doctor's office for a completely routine injection I got bad knees, knee injection. I started actually having a conversation with him, breaking down, talking about the issues that we had with my daughter. So he asked a few questions, and fast forward, he saw my daughter the next week. Fast forward again, he asked a bunch of questions. He did his thing. He really cared about what we were dealing with. A month later, he put her on protocols that started showing literally immediate improvement. I thought we were stuck. He listened. He took action. He did something when there was nothing else I knew to do. He took care of our family, and my wife and I think he potentially saved our daughter's life. It was pretty incredible. So after that year-long waiting list, we finally got a chance to see a child psychiatrist. So he said, okay, it took us a year long to get the appointment. Let's go through it. Meeting took 10 minutes. Child psychiatrist says, holy cow, what he did is exactly what I would have done. Completely blessed the protocol. And literally we see them once a quarter now, and it has been absolutely incredible. So for this is literally why I support this. I support primary care for all Americans, because I think everybody deserves to have experiences like I did.
Thank you, Justin.
Thank you. Thank you so much, Justin. Next we have Ryan McClure. Ryan, can you tell us where
Hi.
Hi, my name is Ryan McClure. I'm from Buffalo, New York. I've worked as a nurse for about 14 years now, and I know how important primary care is. But even as somebody who has worked in healthcare, I don't have access to primary care. This started a few years ago when I moved back to my hometown. I didn't have a job or health insurance, but I needed to keep up my antidepressants. So I went back to my primary care that I had seen for about 10 years before I had left. So he knew me, and he remembered me. He knew me well, but he wouldn't see me unless I had health insurance. I offered to pay full price out of pocket at the time of my visit, but they still denied that that offer I had. So I had to then find the cheapest health insurance that I could, because I needed to stay on my medication. So I did that, but since then I've stopped paying for insurance, and I'm once again uninsured. I work per diem as a nurse. I have 2 different jobs, but neither one of them offer health insurance. And in fact, I actually haven't seen any company offering health insurance to per diem workers. Even if we do work over 40 hours a week, that doesn't matter. It's the status that matters. So now, unfortunately, I have to leave my per diem jobs that I actually absolutely love. And I just accepted a new job this past week, so that I could get health insurance. Healthcare delivery in our country is fundamentally broken. Even healthcare workers like myself can't access healthcare. Ensuring affordable access to primary care provider for everyone is not going to fix everything, but it'll definitely greatly improve the lives of many who are in the same situation as me.
Yeah. Thank you so much, Ryan. And finally, we have Patricia Smith. Patricia, where are you joining us from tonight? And tell us about your experience.
Hi, I'm joining everybody from Massachusetts. I'm a registered nurse and a certified case manager. I've worked in many areas of healthcare over the years, and most recently with a provider hospital organization, which includes a large community hospital and many primary care practices in Lowell, Massachusetts. And Lowell, like many cities, has challenges, including homelessness and substance abuse, Lowell also has a diverse population with immigrants from many countries and cultures. Along with the hospital in Lowell, Lowell also has a community health center, very large health center. And these organizations are vital to providing primary care to residents of the community and the suburbs. Case management, as many of you know, it's a collaborative process, including patients, family, physicians, and other care team members. As a case manager, I worked one-on-one with hospitalized patients after their discharge from the hospital to make sure people have what they need at home and help them sort of sort through the confusing and complicated world of healthcare. And as many of you know, whether it's yourself or somebody else, after somebody's come home from the hospital, many times there are just simple things as which medications to take. And so case managers call patients after the discharge. They can review their medications and their discharge instructions. Case managers can also assist them with scheduling the MD appointment if it's not already scheduled, because that's a vital opportunity for everybody to have that follow-up call or follow-up office visit scheduled with the PCP, preferably before they even leave the hospital. But if not, if they can have somebody to reach out to them and assist them with that. So then also one of the most important things case managers do is to work with the primary care physician, making sure that the primary care physician is aware that the patient was admitted and was discharged and knows why they were admitted and some of the things that went on while they were in the hospital, even though many times they have access to the EMR, the medical record. The case manager can help to fill in the blanks for the doctor. So primary care clinicians know their patients. Oftentimes they know the patient's families and the patient's communities. They can make sure people get what they need when they leave the hospital, and they can help patients realize their healthcare goals over time. In my experience, primary care clinicians and their practices welcome the opportunity to collaborate with case managers to make sure that the patients get what they need. And some primary care practices now have case managers working as part of the practice. And the case managers can follow up with the patients regarding their chronic diseases like diabetes and heart failure, and make sure everyone is up to date with their vaccines, and also to get the preventive services they need, things like pap smears, mammograms, and colonoscopies, so patients aren't falling through the cracks. Of course, too many patients don't have a primary care physician, and too many don't have a great primary care relationship, which makes the job of the case manager more difficult. The case manager can pitch the ball, but it takes the collaboration of the primary care practitioners to hit the ball out of the park. And that's why we need primary care for all Americans, so everyone in neighborhoods and communities gets the health care they need, where and when they need it. It will make us a better nation that is healthier and wiser.
Thank you so much, all of you guys, for sharing your thoughts and experiences. Now, I'm pleased to introduce our keynote speaker of the night, Dr. Rushika Fernandopulle, who's a practicing physician who was the co-founder and CEO of Iora Health, an early innovator in primary care redesign. Dr. Fernandopulle was the first executive director of the Harvard Interfaculty Program for Health Systems Improvement, and is the co-founder and editor of several publications, including Uninsured in America, Life and Death in the Land of Opportunity. He serves on the staff at the Massachusetts General Hospital, on the faculty of the Harvard Medical School, and on the board of Family USA. Thank you, Dr. Fernandopulle.
Good evening, and thank you so much for having me. So I'm a proud primary care internist. It was almost 20 years ago, on a day very much like today, a cold January evening, that I realized I needed to do something drastic. I was working in an academic internal medicine practice. And as those of you who live in the northern part of the US know, it was cold and dark. I had 30 or so patients booked. They all decided to show up. and I barely had time to go to the bathroom, let alone go to lunch. The hospital put in place one of these new electronic health record systems, and I wasn't good enough to do the 4 pages of points and clicks to get my 99214. So I had to scrawl notes on a piece of paper and then spend 2 hours after work while my family was having dinner without me again to try and finish my notes. And it wasn't just me. I had a partner who was doing the same thing, and she said something very profound that evening. She said, Rushika, every day I lose a little piece of my soul. Every day I lose a little piece of my soul. These patients come to us with such big needs, and we have so much training that we could try and help them, but I can't do it. And the system is making it worse and not better. So I realized she was right. I realized I needed to try and fix the system. And primary care is so critical to improve patients' health and their lives. We can help people with their upstream, how to eat and move, with acute and chronic problems, and help them downstream, help them navigate the system. But current primary care is hugely under-resourced. We spent less than 5% of our total healthcare spend on it. It's based on transactions and not relationships. And we've created all sorts of cruft that gets in the way of doing the right thing. So none of this is a secret. What most people are doing is trying to make incremental changes to the system. And I simply realized maybe we have to start over and build a new system that's based on relationships, that's trying to improve health. So in a fit of bravery or craziness, depending on who you talk to, I quit my secure day job. I started a small 2-doctor independent practice in Arlington, Massachusetts in 2004. I called it Renaissance Health, the rebirth of primary care. By the way, really bad idea because I can't spell Renaissance and no one else can. But we started building robust teams around our patients. We built personal health coaches, nurses, trainers, behavioral health specialists. We were in 2004 emailing and texting our patients, letting them see their whole medical record online. We took them for walking groups and cooking and exercise classes. We would proactively reach out to check up on them. We were available 24/7. We never made them wait to see us. You know, some of this might seem obvious today, but 20 years ago, people thought we were crazy. So the obvious problem with all this is that insurance didn't pay for any of these innovative things. All they paid for was a doctor's sick visit. I decided I'd taken an oath to serve my patients, not the insurer. So we'd need to figure out a different way. We simply started by asking our patients to pay us $20 or $40 a month, whatever they could afford, less if they were poor, more if they were rich, so we could provide the care that we thought best. We grew this practice over several years. We learned a lot, but the powers that be in Boston started getting upset at us. We were accused by the health systems of raising expectations, of making their practices look bad. And do you understand that you could be upsetting the status quo, which is, of course, exactly what we were trying to do. The largest health plan in the city knocked us out of their network. They were worried patients might think that we were working for them, the patients, and not the insurer, which of course was exactly what we were trying to do. We decided we needed a new strategy. We were able to build our next set of practices in conjunction with an employer, the Boeing company in the Puget Sound area. So now Boeing paid us extra to double down on primary care, and we could collect the data to show that this could actually make an impact. We did it with the Casino Workers Union Trust in Atlantic City. And by then we got great evidence that this redesigned, more robust care was not just better experience and outcomes, but lower total care by keeping people out of the hospital and the emergency room. So we were fortunate to be written out about by Atul Gawande in a cover article in the New Yorker in early 2011. We decided to leverage this to raise capital to scale the model more widely. My goal has always been to transform healthcare. And the strategy to do this was to simply build a better model, let consumers vote with their feet, and challenge the existing healthcare delivery system to change or lose their patients. So with a partner, I started Iora Health in 2011. We were one of the first healthcare delivery companies to raise a significant amount of venture capital from long-term thinking, mission-oriented investors. We built practices for progressive employers, Dartmouth College employees up in New Hampshire, Zappos employees in Vegas, the Freelancers Union in New York, state employees in Massachusetts. We then moved into the Medicare space, building practices for seniors, for Humana, United, several Blue Cross plans, and eventually got the Medicare Innovation Center to create a new payment model called direct contracting to allow us to serve seniors in traditional Medicare. We grew up to about 50 practices in 8 states. In September of 2021, we combined Iora Health with another advanced primary care company called One Medical. And together we ended up with about 1 million patients in over 200 practices in 30 markets from coast to coast. And in March of last year, the combined company was acquired by Amazon to accelerate their efforts to enter the healthcare delivery market. So it's been a crazy journey over 2 decades. I'm very proud of what we accomplished. We showed very clearly that if we double or even triple down on primary care, invest 10 to 15% of total spend on it, and take away a lot of the junk that gets in the way, and give people the right tools, both people and technology, and build the right culture, that we can show incredible results. Over and over with different populations in different settings, we showed better patient experience, lower clinician burnout, improved health like chronic care outcomes, better self-efficacy, 40 to 50% lower hospitalizations and ER visits, over 20% lower total healthcare costs. And we did this across different geographies and across the income spectrum. So if the goal of our healthcare system is to improve the health of the population, which is what it should be, then we know exactly what we need to do. We need to dramatically increase our investment in primary care. We need to redesign how we do it, and we need to provide it to all Americans. This will not be more expensive. It will actually be cheaper by keeping people out of unnecessary and expensive downstream care, and it will make us more productive and able to live longer and healthier lives. So unfortunately, while all this seems quite obvious to me, our journey shows it will not be easy. We have built in this country a medical industrial complex who, despite the rhetoric, makes obscene sums of money by keeping us sick. We've allowed them on both the payer and provider side to gain unfair market clout. They're some of the highest spenders in lobbying of any industry. So Frederick Douglass famously said, "Power concedes nothing without a demand. It never did, it never will." I believe our only path forward is to create a true movement of patients, healthcare workers, and others to demand the change that we know is needed. We need to recenter the American healthcare system around health and primary care, not doing more. We need to dramatically increase the investment in redesign primary care, geared toward relationships and not transactions. And we need to guarantee this for all Americans. We know what needs to be done. It's now time to do it. Thank you.
Thank you so much, Dr. Fernandopulle, for those encouraging and motivating words. If you have any questions for Dr. Fernandopulle, please post them in the chat and we'll answer them in a few moments or later on our social media pages. While you submit your questions, please let me introduce Drs. Donna Smills and Gabriella Yaru, my colleagues at Jamaica Hospital, who will remind us why this work is so important.
Primary care is about relationships. Someone who knows you, your family, and your community over time, someone you can trust.
When everyone has primary care, communities are healthier because we can prevent disease.
When everyone has primary care, we'll spend far less money on healthcare as a nation, so there's actually money to spend on education, safe and healthy housing, public transportation, the environment, public parks and communities, things that really matter for health.
We mean everyone. When everyone has primary care, and when communities can get primary care from doctors and nurses who are part of the communities they serve, the health of all people improves and improves together. We aim to ensure all persons receive equal health care and get equal health regardless of where they live, how much they earn, what community they come from, or what they look like.
Coming together for this teach and learning, we are that much closer to bringing primary care to all. Together, we can build a healthcare system that is for people and not for profit. And yes, we can provide primary care to all Americans in all American neighborhood and community. Now let's get to your questions. Patty, can you please share some of the questions from the audience?
Absolutely. Hi, everyone. I see a couple of questions in here. Lynn asks, could you expand on how you see nurses contributing to this model?
A great question. Nurses were an incredibly important part. They were the glue that held our practices together. We had one in every one of our practices. They would actually be the ones to help train and supervise these health coaches who are an important part of the model, work closely with the doctors and actually help the patients with their plans. So incredibly important.
Great. Joshua, do you mind coming off of mute and asking your question?
Sure. I'm curious as to what's the size of the panel that an average primary care doctor in your system has. Does it require will this require a huge expansion of the primary care workforce? And how do we get there?
That's a great question. I think, we actually segmented our population a bit. And for the older, sicker people, we actually ran smaller panel sizes. In the Medicare space, we were running panel sizes around 600. In the commercial space, we're running panels that were around 1,400, which is in theory smaller than the typical panel is. I think though, as we get better at this and as we, leverage the use of other people on the team, as we leverage the use of new technology like AI, not to replace people, but to help augment it and actually allow patients to do more self-service, we may well end up with bigger panel sizes. The right answer, though, is we should have enough primary care doctors to serve the population. If we need more primary care doctors, we need more primary care doctors, right? I think in Europe and other parts of the world, we have twice as many primary care doctors as specialists. The problem in the US is we have the flip because of the way that we compensate and hold people up, et cetera. So I think if the answer ends up being we need more primary care clinicians, so be it. Let's actually train them.
Can I jump in for a second, Rushika?
Yes.
Josh, from my perspective, the ideal panel size is probably closer to 600. And we are massively, massively, massively underserved for primary care, both on the nursing and the physician side. And the way to address that is with primary care for all Americans, to work hard at the policy level with states. We basically got to quadruple the number of people we're training if we're going to do anything like take care of the population of the nation as a whole. Remembering that now only about 43% of American adults have primary care clinicians. So when people talk about the shortage, all they're talking about is replacing the people who are retiring. Nobody's talking about getting primary care to every single person. And frankly, that's where primary care for all Americans is different, because we're really talking about what it's going to take to get to the population as a whole.
So just to follow that up, we have a very distorted pay structure in healthcare, obviously, and I'm kind of trying to, so in terms of what incentives there are to enter the primary care field versus, and once you get entrenched in this, how do you all envision changing the mindset of that and overcoming the obvious resistance that the entitled parts of the healthcare sector that are reaping huge profits and making huge salaries? How do you imagine undoing that?
Well, I think, and Rushika, you go after me, but let me jump in and just say, it's going to take a movement. It's going to take working at all sorts of levels, and it's going to take 10 or 20 years of people really putting their heads together and figuring it out. If you ask me, we need to make or professional training in primary care free, with obligations to practice in communities. There's no reason we can't do this with current economics, except that we haven't thought about it. Most people don't know that almost all residency training in medicine, and this is not nurse practitioners or PAs, but in medicine specifically, almost all residency training is publicly funded. We've known for years that 50 to 60% of our professionals should be primary care folks. Why don't we require that hospitals spend 50 to 60% of the money they make on graduate medical education on primary care? The only reason is that all of us haven't gotten together and effectively, as Rushika said, demanded it. Rushika, your turn.
Yeah, so these are all about power imbalances. The reason why primary care gets paid so much less is because of the RUC, right? The way that we set the relative value fee schedule is based on a committee which has 28 or so specialists and 2 primary care doctors on it. Guess who gets paid more based on that power structure? So the way we got around that, by the way, is we simply went right around it. We didn't get paid fee for service. We took what was called the total healthcare spend. And now what we can do is allocate money based on the value being created. The value that can be created by primary care is staggeringly high. staggeringly high in terms of outcomes, productivity, and lowering total healthcare costs. Lowering that, so right now, primary care is 5% of total healthcare spend. If we can lower total spend by 20%, we could quintuple the amount of money going into primary care, quintuple it, and still be the same off, right, as we were. So this is all about power dynamics, which is why I agree with Michael that we need a movement to actually change these power dynamics.
Let's do some more questions. Patty?
Well, we have a lot more questions here. We are getting close to time. So what I will encourage you guys with is to have our team look at these questions, answer them on Facebook. Also, feel free to stay on the call and do questions with our leadership team right after this. Thank you so much, Dr. Fernandopulle, for your time and sharing your insights on primary care. Dr. Fine?
In the coming Zooms, we're going to be talking lots more about how we build this movement and succeed. Build a movement. Building a movement is a crazy, huge undertaking. You know, it's building a movement like the abolitionist movement, the movement for women's right to vote, for the civil rights movement, movements that succeeded and made America a better place for everyone. It means we're going to have to involve thousands of people in every neighborhood and community. It's going to take way more than somebody just passing a law in Congress to get this done. Way more. It means everybody's going to really need to go out and talk to their friends and neighbors and communities and bring them in to help, because we all got to do it together. Healthcare impacts all of us, but when we work together, there's nothing we can't do. So let's all reach out to colleagues, families, and friends and bring them into this movement. This isn't a Republican thing. This isn't a Democratic thing. This is an American thing. The cost of healthcare affects all of us. We are the public in public health. The time is now.
Thank you, Dr. Fine. Thank you, everybody. We encourage everyone to find someone new, bring them to our next Zoom meeting on February 6th. Our speaker at that meeting will be Dr. Wayne Altman, Chair of the Department of Family Medicine at Tufts University. He'll be speaking on the PC4AA legislation in Massachusetts and how we can work together at the state level to provide primary care to everyone. Register on our website, www.primarycareforallamericans.org. While you're there, click volunteer to let us know how you'd like to be an active part of our movement, or hit donate to support our work with a contribution. Every little bit helps. Once again, we need and appreciate every single one of you for helping us spread our movement across the nation in order to get the change you need and we deserve. Join us again in 2 weeks. Bring one person, or maybe bring 3 or 4. Healthcare for people, not for profit. Primary care for all Americans.
Please take a minute to take our survey that's in the chat. We want to hear from you. If you would like to talk with members of our leadership team, stay on our call, and the board members of PC4AA will stay on to hear your feedback and help us grow as a community.
Thank you, everyone. See you on February 6th.
Thank you.
Thank you all.
Thank you.
Questions? Just shout them out.
Hi, this is Christina Yuri. It's my first time calling in. Glad to hear this topic. I'm just curious, do you see health tech such as chronic disease management apps and platforms supplementing the primary care efforts nationwide?
Why don't we ask other folks? Rushika, what do you think?
So I think absolutely. I think that, we had an investor, kind of Vinod Khosla, who kept saying that we're going to have computers replace doctors. I think that's ridiculous. I think there are things that machines can do to unload a lot of the crap that we currently do that is not, necessary. I think there are a lot of things that we do as humans, as doctors and nurses and other healthcare professionals, which computers cannot do, right? And maybe in our children's generation they will, but certainly not now. So the right way to think about this is actually, how do we leverage the technology that's out there as adjuncts to the people to try and deliver better care to people, right? So I think that's clearly a role for both.
Great question. Christina, where are you from?
I'm from Jacksonville, Florida.
Welcome. Great.
Thank you.
Somebody else.
Good evening. Thank you very much. I'm Jim Meltzer, and I practiced otolaryngology for a long time, and I posted a question because the big problem is enticing medical students to go into primary care. I mean, without that, the manpower is not going to be there. So how is that being addressed?
Rushika, you want to give a run at it?
Yeah. No, so part of it's the money, right? So part of it is we need to change the economics. So you don't make 3 times as much be sitting in a dark room looking at films versus becoming a primary care doctor, right? And I think most other countries get the balance much better than we do. So we need to fix that. But maybe a more important thing is we need to create a compelling vision of what it's like to be a primary care doctor, right? With, panel sizes of 600 and robust teams and great technology and being able to build a relationship with your patients and not having to do these stupid coding games and having to punch and click these things to generate billing codes. And if we create a better job and create better economics, I don't see why people don't all go into primary care.
So
Great answer.
I agree with Rushika. I think it's really important that we meet the now quintuple aim. Money is part of it, but we have to improve the job satisfaction for primary care doctors by making their jobs more rewarding and more satisfactory for the care that they give, because we know we're the ones that make the difference in what we do every day.
Michael, this is Larry Bauer. I'd like to jump in on this question.
Sure, please.
So one of the reasons we don't have enough people going into primary care is because in our admissions process, and I'm speaking particularly to medical schools now, in our admissions process, 75% of the kids getting into medical school come from families of significant means. And those people are not going to pick primary care. They want to make more money than mommy and daddy make. And so they're going to be oriented towards income expectation. But we know from 30 years plus of research that if we get more kids from rural communities, if we get more kids from first generation to college families, and we've got plenty of them out there in both rural and inner city communities, if we really had an effective program to help them to be competitive to get into medical school, and they got in, we would have more graduates choosing family medicine, general internal medicine, even general surgery. So attention to the admissions process, and that means pressure on the deans and the board of trustees of the various universities and medical schools. And that's part of a social movement. They are all susceptible to certain kinds of pressure, political pressure, media pressures, et cetera. So we've got to figure out as a part of this movement, how exactly are we going to help our local chapters and overall, we as an organization to have that kind of impact.
Thank you. Dudley Burge.
Yeah, hi. I live in Philly and work in New Jersey on the board of a large health plan for state workers there. And, we established a program of direct primary care a couple of years ago with limiting panel size to 1,000. And I've kind of followed this, saw very good reviews about Iora and Oak Street and so forth. But I have a great concern, just wondering what people think about. When you take venture capital money, ultimately, yes, the first years it's, we're willing to take a loss. But then, the piper comes and, like you see with the ride sharing things now the prices have doubled and tripled, right? And they're making profits. And kind of how you deal with that, because I'm not going to mention the name of a particular company, but it's like a large company that provides most of our centers. And, it's been one of these companies that's gobbled up lots of very solid primary care companies. And, the founders disappear then, right? The people who really had the zeal for it, and kind of how you deal with that problem. And, I think we're unique in the world with having the profit motive the way we do.
Rushika, do you have an answer? And then I have one after you.
And then I have one, Michael.
Yeah, I think the reason why people like us have had to go to private capital markets is because the public funding has been non-existent for primary care in general, right? I think if there were other alternatives to be able to fund some of these things, I think we would be one of the first people in line to do it. By the way, I think this idea when we created accountable care organizations, the idea was correct, but we sort of centered it with these humongous hospitals and these big health plans. I sort of wish we had created sort of accountable care communities, which is part of what I like about the movement that's starting to bubble up. What if communities could fund their own primary care and could somehow provide this sort of funding for people? That would be a much better sustainable source of capital, right, to get these things off the ground.
Alan, why don't you go? Because Rushika just gave my answer.
All right, so if venture capitalists are going to take over primary care, we're dead, because this is not about profit. This is about patients and healthcare, and venture capitalists are about profit. So it just doesn't go together. I'm sorry for everyone who agrees with that, and I'm happy for the comments that were positive. But if we're going to go that way, we're doomed. I guess I'm ready to retire. That's not why I went into medicine, but we have to take venture capitalists out of primary care. And there needs to be primary care for all Americans. As Dr. Fine says, my mentor, in every American city and neighborhood, and for all.
Thank you. Sandy, great to see you.
Great to be here. And I want to move us away to talk a little bit about the other members of the team, as I have done for my whole career, besides the physician. And an innovation that I think was part of Iora, but I'm not sure. And I want to check on that. I had a long conversation before a book that I wrote in 2019 with Andrew Schutzbank, who was very active in the company at the time. And he described the way integrated care worked in terms of behavioral health and other members of the team, but you had a role that you called, I believe, the health coach. And the health coach was someone with, as it was described to me, who was good at relating. That was the basic requirement. And maybe they had a degree, and maybe they had a lot of degrees, and maybe they didn't have a degree. But this person had their own panel. And it was about a third of the physicians' panel. And so when the patient came in, they would meet their health coach, and the health coach would take them to the room and would talk about their health needs and goals, which the health coach knew well. And then, and this was genius, the physician would come into the room and the health coach would stay, and the health coach would become the scribe. And the only technology in the room was on the wall. There was a big screen on the wall and the health coach's laptop. And so the meeting would go forward, then the physician would leave and the health coach would stay and follow up. Did you understand? Do I need to make some appointments for you? So forth. And that these people can become the pathway for community into a career in healthcare. The folks from a community who are good at relating, who maybe are bilingual for their community language. And I think that's genius. And I made a couple of presentations on it to big organizations, hoping that I knew what I was talking about. What do you think if I did?
So you got it exactly right. So I just had breakfast with Andrew Schutzbank today, actually. He was worked for us for many, many years. I don't love the word health coach, by the way.
I don't either.
The word I like is the one that Paul Farmer used. He called these folks accompaniteur, one who accompanies you in the journey to health.
Ah.
Now, the problem is I can't spell accompaniteur, like I can't spell Renaissance, but we didn't use it. But that was, it's the key is in typical fee-for-service medicine, I, the doctor, get paid for telling you what to do. So I have 7 minutes. I say, you should eat less, exercise more, take your medicines. Good luck, sucker. I'll see you in 3 months. And I actually don't give a whit whether you do it or not. In our model, because we were getting paid to actually keep people healthy, I would need you to do it. But that's hard. That's why we needed these health coaches or these accompagnateurs. We had 3 per doctor. These were from the community, spoke the language of the people they served, picked for empathy. They could do anything. They were great jobs. One way to think about what we did is we were putting a bunch of cardiologists doing bogus procedures out of work. And for every cardiologist I put out of work because they're not doing these bogus procedures, I could hire 10 health coaches.
Yes.
That's great economic development activity, by the way, for people.
And
so it's a good
and
job.
And these people know their patients so well. And that knowledge and their knowledge of the community is a legitimate expertise set that belongs on the health team. And those people then go on to administrative positions. They grow, they go to be nurses, they go to be social workers. And what's crucial is that primary care think of itself as the front end of the education of its own team, rather than waiting for the academy to get its act together to do that.
Yep.
Thank you.
Couldn't have said it better. Thank you.
I want to make sure we get to Scott and Jim Meltzer, but first I want to go back to Jimmy Tingle, who had his hand raised for a moment, and see if he's willing to chime in.
Hi, thank you very much. Great panel. You kind of touched on it earlier when you were talking about venture capital. My question was, what is there currently a role for government tax dollars to be invested in the primary care system? Number one, and I heard the doctor say he didn't think there was, or there's very little, if any. And the other thing is, you know how the government will invest in teachers, it's just students going into college, and part of the deal is when you get out, you'll teach in a certain area for a certain amount of time to then pay back the loans. Or how about that idea in terms of medical school, signing people up to become primary care, paying for their education with the expectations and the requirement that they would go into the primary care field?
Jimmy, you just told my story. I was a National Public Health Service Corps scholar, and you paid for my education, and that gave me the opportunity to spend the rest of my life giving back. Rushika, what do you think?
Well, you are welcome, sir.
Thank you.
I think one of the problems is the cost of medical education has gotten so out of reach for most people. People are graduating with $250,000 of debt. That's more than a mortgage. And then we expect them to take low-paying jobs, right? Which makes it very, very hard. So we also have this medical education complex that has gotten way overpriced, et cetera, that we need to fix, I think. And again, public in most other countries, that medical education is publicly funded, and in return for that, you give some service for several years, right? And I think that's not a bad idea that we move to that model. And there's some of it through the National Health Service Corps, but not nearly enough.
And the numbers are a fraction of what they used to be. There used to be 3,000 people with those scholarships in the field. Now I think it's down to about 50 a year. Scott Hansen, it's great to see you again.
How are you, Mike? Fine.
It's way too long, brother.
Yes, sir. I'm up in Maine. I'm the president-elect of the Maine Medical Association. So where are other states with like-minded physician leaders that are trying to, I don't know, I think the direct primary care and the direct medical specialties, that's got to be one of the hearts of your movement. We're already cutting out the insurance middlemen or the hospital-based systems. I think it's going to be incremental over 5 or 10 years, right? So what are there any models right now? Do the large purchasing groups want to get involved with this kind of an intervention? Puget Sound, the chambers of commerce and the people that are paying through the nose as employers now, they know the system's completely screwed up. So why aren't we let's work with them, and then hospitals and other pieces of the puzzle will come around.
Take a look at our website. From my perspective, and I think from the perspective of Primary Care for All Americans, we think this needs to come not from big organizations, but from neighborhoods and communities, and that we build this from the ground up, not from the big guys down. Rushika,
Okay.
what do you think? Rushika, thoughts?
Yeah, it's just, so the employers, I think, are a great set of allies for us. They have been sort of asleep at the switch for the last 20 years and just taking, what these crazy rates and buying crappy healthcare. That's starting to change. We've been doing some work with the Pacific Business Purchase Business Group in Health, PBGH. We did some work with the Boeing Company, with a number of other big employers. I think, like all movements, this starts with consumers, people, patients, but then who are the other people who are allies? And I actually agree with you that having payers, the right sort of payers as allies, are exactly the right thing to do.
Thank you. I'm going to get to Jim Meltzer in a second. Jim, I think you've had one question. I just want to call on Lynn Blanchette for a second, if you don't mind me putting you on the spot, because you often have pretty strong thoughts about the contribution of community nursing to this whole process.
Well, that was me in the conversation group that said, can you expand on the role of nursing in the currently proposed model? I'll just start with the comment that I'm not really comfortable being anybody's glue. I've been a professional nurse for 42 years and have multiple advanced degrees and lots of clinical practice experience. I suspect that the nurses in your practice contribute a lot more than glue and actually have a skill set that grows and contributes to the well-being of everyone who works in your organization, including the patients. So let me clear the air on that one. We never talk about physicians as being anything other than skillful providers of care. We don't use words like glue when we talk about them as professionals. So I want to make sure that everybody here understands that that's my perspective on us as a member of this conversation and on the team. I am aware of lots of places where registered nurses contribute, not in the role of nurse practitioner, but registered nurse licenses contribute to the health and well-being of the people that they provide direct care to. There are lots of places around the globe where the nurse is the primary person that children come into contact with for the entirety of their childhood, unless they've been assessed to have a developmental or medical need that needs to be referred to a provider level clinician. And I think I started out my nursing career doing exactly that with moms and new babies. So until the role is fully expanded on and nurses are allowed to practice to the full scope and standard of their license, we're missing an opportunity to provide care to people, in your clinics, in your health centers, and in the communities, right? So I think, and the other thing I will say, and I said on the first night that we met, is that there needs to be some sort of connection between the clinical work that people are doing in their primary care practices and serving the needs of the community in which they practice, beyond the direct patient or one-on-one interaction that you provide with the people who come into your practice. I rarely talk about the people that I provide nursing services to as patients of mine, unless they are in the illness role. So I just have I think a slightly different perspective on, how this could all be made more expansive and acceptable to people.
Thanks, Lynn.
You're
For those
welcome.
of you who weren't with us, Lynn was our first keynote speaker and told us about Situate, Rhode Island, which is the only place we know of in the United States where everybody's guaranteed access to primary medical and dental care. And Lynn has been instrumental in making that happen over the last 25 years. Jim
And where
Meltzer.
taxpayers pay for those folks in that community to get the primary care that they need. So we have a model where taxpayers are supporting people in the community to get primary care.
Thank you. Jim.
Okay, very nice. Thank you, Dr. Fine, and the rest of you good people for educating me. Number one, I didn't realize that so many of the medical students are from affluent families, such a high percentage, which you've already touched on. Really, the other question I had, which was if you want to entice people from less affluent backgrounds, who's going to pay for the education? I mean, it's huge, like you said.
I think it's a public responsibility. Pat. You're on mute, Pat. Pat, you're still on mute.
I'm off mute. Okay, thanks, Michael. I wonder if you could educate us a little bit about the role that federally qualified public health plans serve in this country. I know it's a lot of people get their health care through them. They would seem like the ideal model to adapt this primary care intensive approach because they're already integrated in the community. They're already trying to provide primary care to large numbers of citizens all around the country. What do you see that pathway as being possible for this movement to grow?
Rushika, what do you think?
So there are a lot of FQHCs, federally qualified health centers run by the Bureau of Primary Care that's federally funded. They take care of people, typically on a sliding scale, and they provide great service to many communities. They're not enough, unfortunately, right? And I think the other problem is they are still stuck in this transactional fee-for-service billing model, and that prevents them from doing the right thing. There's no reason that couldn't change, by the way, but it just happens to be the way that they get paid. And so I think it's a good base, but needs some change. And if you probably know more about this than I do, Michael.
Well, I'm not sure I know anything more, but I will tell you that the perspective of primary care for all Americans is each community needs to figure this out for themselves. Some communities will choose to rely more on community health centers. Some will choose to rely more on direct primary care. Some will choose to rely on some other organization or arrangement. But the important thing is for each community to get this going for themselves and to own it themselves. And we don't try to impose a one-size-fits-all approach, but instead recognize that the goal has to be, the prize we need to keep our eyes on is providing primary care to every single American. Scott Connard, you had your hand up for a second. You want to jump in?
Well, I just would like to say that, first of all, Rushika, thank you so much for being here tonight. It's been great to have you, and what a joy to hear your perspective. And, the influence that you've had has been legion on the field. Alan Roth is on tonight. The community worker approach that you've got, I see in his clinics with the navigator position that he has, that make sure that people understand what the clinician has said, what they're doing, and make sure it's followed up. So, I appreciate so much Dr. Roth's taking the teaching that you gave us with the importance of having that extra person on the team that really walks the person through the process of care. And Lynn, with the RNs that Alan has in his offices, and playing a really key role in making sure that they are available to triage and also to walk out and make sure that people get appropriate care in the clinic. So I guess my point is that so many of the lessons that we're hearing tonight are being put into actual patient care across the United States. And the last thing, I guess, that I heard is how do employers get more involved? And I work with right now about 60 different employers who want to buy prepaid advanced primary care, and there's not a system. Blue Cross, United, Cigna, Aetna, they don't want to fund primary care the way that we're talking about. They don't have systems to do it, and there's no selfish kind of interest for them to do it. If they decrease the total cost of care, it doesn't serve them. So they are not embracing the model, and they haven't supported it, but there are many, many other people who have, and we're getting to the point that corporations can now buy primary care in a prepaid advanced primary care model. And as that becomes more available and is paid for by corporations, we'll see it expand dramatically. So it feels to me like, while we may not be at a tipping point, we're really coming along well. And whether it's taking the lessons that Iora and Rushika taught us and incorporating it in a large medical practice in the middle of Queens, New York, which is what Alan Roth is doing, or it's corporations buying a prepaid advanced primary care model. It's coming to pass, and that'll just be a part of what you've talked about, Dr. Fine or Michael, with every community figuring out how they can make this happen for them. So I'm very optimistic and see leaders like the people on this call tonight really contributing so significantly in the changes in the United States.
Amen. Pat, did you have one more thing?
No, actually, Michael, I was going to chase down Scott, who put his hand up and took it down and say, Scott, come on, we got to hear from you. We want to hear about the employers. So thank you, Scott. That particularly gives me some hope. You know, we've been sort of wringing our hands about this thing ever since I was an undergraduate student many years ago, and it's wonderful to see so many young, enthusiastic people being successful, like Rushika and Scott and Alan, and actually making a difference and seeing things happen. So I think that's a wonderful place to bring us, Scott. Thank you for that positive approach.
I think it's really important. You know, I got some positive feedback. I love that. Thanks, Scott and Michael. And, you know, the word that Rushika said, but it is not one answer to this problem. And, you know, and I think that's what our organization is about. It's not about, you know, what is the right thing. It's what is right for each community and each county and each state, but to ensure that every American has access to primary care for all. And that's why we're trying to be so broad as an organization, because there is not one solution to the problem, and it's going to have to be multiple solutions to the mess we're in.
It's about building the movement, which means we really, really need everybody to come back in 2 weeks and bring one person, 2 people, or 10 people, you know, until we get to those thousands it's going to take to make this happen, until we get enough communities that have 10 people each who are ready to roll up their sleeves as a work group for us to support, so we can show the nation how this is done all across the nation. Rushika, I don't know how to thank you enough for your kindness, for your leadership, you know, for just your human decency, and for being with us tonight. And I don't know how to thank our amazing MCs and participants for helping support this by saying the things they said and working so hard on getting this Zoom together. Thank you all. We really hope to see you in 2 weeks with 10 or 20 or 30 more people until we get to this, the kind of sort of political power that Rushika talked about, which is what it's going to take to make the change we need to make. Thank you all. Good night, and we'll see you in 2 weeks.